thank you for joining us for another episode of Matters of the Heart, a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name is Dr. Srivastava. I'm a cardiologist here in Haverhill, and with me today is one of my colleagues, Dr. Seth Bilazarian. And we're going to talk about a topic that I find very interesting because I think it can make patients' lives much more easy and convenient, and that is an issue revolving around doing some blood tests at home as opposed to in the office. There's a medication that many of our patients take called Coumadin, also known as warfarin. It's a common blood thinner that's used for a variety of conditions, such as atrial fibrillation, or if one has a mechanical heart valve, or if it had blood clots. And currently, it's a very effective medication, but can be a little bit of a nuisance. It requires frequent blood tests early on, hopefully with good control, ends up being monthly blood tests, but still requires trips to the doctor's office. And lately there's been some new developments where these can be done at home, and so Dr. Bilazarian today will be talking a little bit more about that. So with that, I'll hand it over to him.
Great. Well, that's a fantastic introduction. So as you mentioned, this medicine, Coumadin or warfarin, until recently was really the only treatment available to prevent strokes in this problem called atrial fibrillation. And we've done a program on that before, and that's available on our website for those who want to see that again. But the Coumadin management issue is a complex one, as you mentioned. It can be very difficult to keep patients in good control, and the issue is that patients have to have regular checks, a minimum of once a month, but initially quite a bit more frequently to get them into a good range. I think there's certainly a trend we're seeing with more and more patient involvement with care. We see it with the diabetic patients checking their own blood sugars. That's become really a standard that patients check their blood pressures at home. And this is now becoming to be the similar thing with the warfarin management or Coumadin management. And it's the same kind of concept. I think the analogy with the blood sugars that diabetics have to do is similar. Patients would have to prick their finger, put the little drop of blood on a tester, and then get a number that they can then use to help guide the blood thinner control. So that's really what we're going to talk about. This is a pretty common problem in the United States. There are as many as 4 million people in the United States on Coumadin, and these patients all have to have their levels checked regularly. There is another development in this that I will mention just before we go much further on this, is that there's another medicine that's just come on the market recently called Pradaxa, which is an alternative to Coumadin that does not require testing. So we have Coumadin, which traditionally required you to go to the doctor's office, get a blood test, and be managed about how to adjust your dose. But now we have 2 new developments. One, maybe an easier way to use Coumadin, which would be to get it tested at home, or this other drug called Pradaxa, which doesn't require testing at all. So there's some options available for patients, so it's kind of exciting.
And the one thing I would add about Pradaxa, it's a new blood thinner that we can use, but it's not a blood thinner that's being used for mechanical heart valves. It's specifically for the condition of atrial fibrillation. So a little bit of a difference.
Right.
But so how does where to go to next with this? So with the home testing.
Well, it just became available for a broad group of patients around 2009 to 2010 when the Medicare payer called CMS, the government group called the Center for Medicare Services, approved the use of these devices so they could be paid for at home for patients to get one of these devices to check home use. So we've just had it now, and the adoption has been quite slow. In our office, we cover several hundred patients with these Coumadin doses and Coumadin testing, but we only have about 10 patients using the home monitoring. And it's just starting to become more commonly adopted, more comfortable for patients, for doctors, and the insurance companies are sort of embracing it now that the government payer, Medicare, has decided to use it. So I'm mentioning this now because I think I want to start to have our patients thinking about it and talking with us about it.
Is there an added cost to the patients, generally speaking, or how does it work from that standpoint?
Well, we could talk about that, but I think the general approach is to investigate it, I guess is the way I would answer that question. It's hard to answer the question. It is covered by Medicare, but I think most of our patients know that Medicare generally covers 80% of costs. So if patients have a secondary insurance, we have to actually look at that secondary insurance. Do they have Blue Cross or Harvard or Tufts or AARP as a secondary insurance, as an example? There are others. And does that secondary insurance cover the other 20%? And does it cover all or part of it? So it's hard to answer the question, but it is covered, but to the extent of how much is covered, it has to be investigated. So generally, the mistake that I made in the past was, for some of my patients, is we didn't really look into this fully for all the costs, because there may not be costs for the initial instrument, but there may be costs for strips. So we're now doing a better job saying, let's look at all the costs and then make a judgment. This is going to cost this much or this little, and then make a decision about whether it's something the patients want to do.
Great. So now let's say someone wants to do it. What can we tell the patient about how accurate this is, or how does it compare to doing the traditional, come to the office for a blood test? Is it just as accurate and just as effective?
Well, in terms of some aspects of what you asked, of course, the convenience factor would be significantly greater. Yeah. Being able to test at home for patients, some of our patients are elderly and it's a hardship to get out of the house. For some patients who are traveling, just the convenience factor, I think, is a big part of this. So I want to just comment that clearly this would be preferred to come into the office if possible. So I think that that's a big part of it. But in terms of the testing, there has been pretty good validation. There's some competition between the three makers of these devices. Some claim to be more accurate than others. So that's part of it, decision-making as well. But generally, it's been pretty well accepted. Some of the other large institutions in the greater Boston area are now using this as part of their approach to management of patients with Coumadin. So I think that it's becoming more commonly adopted. So I think that there is generally a feeling that it is compatible or consistent with what we would get in the office.
Great.
But I would like to just review what you started to say. I want to just review that list of things that we talked about. So commonly, Coumadin is used for atrial fibrillation, but it's also used, as you said, for mechanical heart valves. So patients have a heart valve that's replaced that's made out of metal. They would use a mechanical heart valve. They have to be on Coumadin. Patients who have clots in their legs that come back repeatedly, that's called a deep venous thrombosis, or a DVT. Or patients who have clots in the lung called pulmonary embolism repeatedly, they have to be on Coumadin chronically. Or patients who have other kind of disorders that just cause them to clot a lot. So there are other causes where patients have to be on Coumadin for a long time, but as cardiologists, we see the two most common ones being that atrial fibrillation problem or the mechanical heart valve.
Now, as many of our viewers probably know, Coumadin is a medication that has to be kept within a relatively narrow therapeutic window. We don't want to have the blood too thin, or we don't want to be undertreating either, and that's what the whole point of it. Now, I've heard some of the purported benefits of the home testing is that you are more likely to remain within a therapeutic range compared to the old conventional method. Is that true? And if so, maybe you could talk a little bit more about that.
Yeah, let's talk a little bit about, let's step back from what you said, because I know you know this well, but our audience, just for review purposes, generally speaking, for most patients, we want the blood thinner level called the INR. The INR stands for International Normalized Ratio, fancy doctor words, but basically it's like saying how much thinner than normal is your blood. So if the number is 2, it means your blood's about 2 times thinner than normal. And if it's 3, it's about 3 times thinner than normal. And I use the numbers of 2 and 3 because that's about the range we like people to be in. We believe that that's a safe range. It's not too thin and it's not too thick. So 2 to 3 is generally the range we use for most of our patients. There are some others that are a little different, but most of the patients it's 2 to 3. So if a patient is much higher than 3, over 5, for instance, we think that the risk of bleeding is very significantly higher. Their blood is too thin. And if it's below 2, significantly below 2, 1.7 or 1.6, they're not getting the benefit of Coumadin. Their blood is too thick. So as you said very well, we want it to be in that range. So we have a graph. I just want to show one of our few graphics we have today is a picture of what it looks like. And it's a big U here. And you can see at the bottom, the U shows that you have low event rates of bleeding or strokes or any kind of problem if you're in the range of 2 to 3. You can see the numbers of 2 to 3. But on the other side, if you go out to higher of 5 or 6, the bleeding rate goes up a lot on the right side of the U. On the left side, if you're much below 2, down to 1.5 or less, the stroke rate goes up. So we're not protecting you. So that's really what we just said in sort of graphical form. So if you're in that range of 2 to 3, you've got a nice level of low risk and high benefit for this drug. But as you said earlier, it's sometimes tough with our patients to keep them in that range. And the problem with Coumadin is it can get out of whack with a variety of things. And we've talked about this on a prior show, but for purposes of review, if you take an antibiotic, you get sick and you need an antibiotic, your Coumadin or INR level will go out of whack. If you eat certain foods, our patients know they have to be careful about some kinds of vitamin K containing foods. If they drink alcohol, a variety of things can make it go out of whack. So the idea is if you have home testing, not only are you able to test more frequently, but you can actually do it if there's anything that causes any issue. So we have patients that call us and they say, I have some nose bleeding, or I have some blood in my stool, for instance. And we like them to come in right away and get tested. But if you had a home test, you could test right away and tell us, is your level high? And then we could make some adjustments in that regard. So, but to answer your specific question, there is data that suggests that because patients can test more easily, they can be in this range of 2 to 3 more frequently. One trial says that patients who tested at home were in range 56% of the time, whereas patients who tested only through the office were in range 32% of the time. Now, this has been criticized. So many of the places that run good Coumadin clinics like we have, or like other places like Massachusetts General Hospital or Leahy Clinic, they claim rates of 70% of patients in range with management at the hospital. So some of this data may be old. I mean, if you do a lousy job with either approach, you're going to do a lousy job. But the question is, if you do a really good job, can this help you? And I think the data suggests reasonably well that it can help you. But one recent study that I think looked at this that answers the question more specifically is if you do a really good job with the office-based method of every month and you're on top of it and checking it frequently and adjusting it frequently if needed on a once-a-month basis, or you do it at home every week, they're about equivalent. So we know that if you do a really good job, you're doing a really good job at both. So the question here really is does it provide a level of safety and convenience for a lot of patients?
I think it does, certainly.
I think it does.
One silly question to ask about logistics. When a patient does this at home, they just prick their finger, put it on, get a number. How does it work now? Do they just pick up the phone, call you, the doctor, and say, hey, I got a 2.1, what do I do? How does that work?
Well, that's a good question. And there are 3 companies that are currently doing this, and they're the manufacturers of these devices. And these devices are the ones that we'll show a picture of shortly that actually measures the number. So it gives you that number between 2 and 3 if you're in good range, for instance. And that device then either coordinates with that company or the patient calls it in. And then by internet or by phone, it's sent to us physicians. The reason that it's valuable is that through the computer checking and variety of other techniques, the company can make sure that the patient does get checked on a regular basis. So that sort of follow-up that's required can be done by another person that allows the patient to get close follow-up.
Gotcha.
So one of the things, though, that I will just say is that the frequency, though, does seem to suggest that there is some benefit. I think it's sort of a common sense that if you check more frequently, you'll be more likely to be in range than if you check less frequently. But I would just emphasize that I don't think that there's, at this point, a big reason to recommend this as a superior thing over checking in the office, assuming it's done well. So I do want to emphasize, though, that there are times where patients have told us that it's very hard for them. And I've over the years had several anecdotes that I think are fun, and maybe some of the patients who these anecdotes pertain to might be in the audience. I had one patient who walked the Appalachian Trail with atrial fibrillation and was on Coumadin. And it was an extreme hardship. This was 7 or 8 years ago. And he would have to come off the Appalachian Trail and find a place in Georgia as he was coming north, or in South Carolina, North Carolina, as he was coming north to find a place to get his Coumadin checked once a month, then call it in, and then he would be back on the trail, and we'd have to figure out a way to get the information to him. So it was a real hardship. And there are blogs on the internet dealing with this. What do you do if you're traveling out of the country? If you're traveling in the United States, there's many labs. If you're in Florida, you can get lab testing pretty much wherever you need to. There's these national chains of labs that will do your Coumadin testing. So our snowbird patients in Florida or elsewhere can do it pretty easily. But if you're traveling out of the country in Europe, or if you go to Mexico or South America or Asia, it might be very difficult to do that. So this could be another reason why you might want to have a home testing kit that would really not be a home testing kit, but be take it on the road kind of test. Yes. So I would just comment that might be an example of why this would be superior, because it's hard to test otherwise.
Yep, I agree. So clearly there's benefits for patients from a convenience standpoint, and it seems like it, when done properly, also clinically too, might do a little bit better. How about over the long haul? What are some of the benefits, perhaps on cost, for example, and other?
Right. Well, I think that it's not really cynical to say this, but I think that the government, the payers like CMS, the Medicare payer, is looking at cost and probably did look at that. I'm guessing, I have no proof, but guessing that looked at the cost of Coumadin management and said that there might be some benefits to this, because we know if you're out of range and you have a bleeding problem and you have to be admitted to the hospital and get blood transfusions and surgery and a variety of things, that's very costly. And on the other end, if you're low and you have a stroke and you have to get treatment for that, that's very costly. We as physicians are worried about cost, but we're chiefly worried about the medical outcomes. But as the payers, they're looking at the cost and they're saying, it might be worth giving a device that costs a few $100s, but in the long run could save money if we can keep patients in a good range. So I think that there is a part of that, and there is some data that suggests that the costs related to bleeding and consequences of clot formation are pretty significant, and that the cost of getting that down could be benefit could be provided to getting those costs down by getting patients in range. So some of the benefits that I just want to take a moment to review is that this strategy now seems to be approved by most insurance companies ever since the Medicare federal payers approved it. You have to be on this Coumadin for 3 months, and you have to be committed to it for lifelong treatment or prolonged treatment. So it can't be you're on it for 3 or 6 months, you wouldn't get approved for this. So that's one thing. The one value is, as we mentioned, is you get the test results immediately. So if you got a bloody nose or you have some kind of problem, even if it's not life-threatening, and you want to know is your blood thinner level out of whack, you can test right away. You don't even have to test during hours. You can test at 10 o'clock at night, find out right then whether your level's high or low. So that's another value, immediate test results. There might be some benefit we talked about in reducing complications of either too high the blood thinner level or too low a blood thinner level. It certainly saves time. I mean, I think that 2 or 3 minutes at home beats coming to a lab. We pride ourselves on getting our patients in our lab quickly without waiting a lot. But of course, there's waiting, there's coming, there's parking, there's time away from work. So there's that benefit. We mentioned the convenience of fitting into your schedule. You don't have to come just when a lab is open. You can do it nights, weekends. I mentioned the anecdote about the Appalachian Trail or being overseas. There was a blog about there's a blog on the web of patients who travel around the country in recreational vehicles, these big Winnebagos, and there was some blogging about where can I stop to get my Coumadin checked. So you could have your INR tester in your Winnebago if that's something you do, as an example. So the convenience factor. I think that more and more there's a number of our patients that really do want to be more active in their care. I mean, they're asking questions, which we think is great, and they're saying, why are we doing this, and I want to understand more. So this is an example of how they can be really proactive in their care, and it gives them an element of control so that they can help with that. And I think that with that control, for many patients, there will be less worry. So I think that there are some benefits for patients in this regard.
Great. All right.
So one of the things that I think that I would just go through is asking some simple questions. And there's actually on the web a question survey on the Philips Medical website. If people Google Philips INR testing, it's one of the manufacturers of these devices. And they have a little interview. You could just click off yes, no on these answers. And one of the questions is, do you take Coumadin? And if you say yes, yeah. And do you have one or more of these medical conditions like atrial fibrillation? And we already covered that. And then the next question is the one that we've been talking. The question is, how would you answer this question as a patient? I'm good at following doctor's orders and prescription instructions and would agree to perform regular testing prescribed by my doctor. So if you say yes to that, that will be another good thing for considering this. I want to have greater control of my own testing. If you say yes, that's another good thing. I'm physically able to check myself, or I have somebody who can help me. If you're perhaps an older person who might have a family member that needed to help you, would that person be available as another example? Another question is, I prefer not to have to travel to the doctor's office. That would be another reason. I'm unable to or dislike providing a blood sample from a vein. So one difference here is that you come in, you get a tourniquet put around your arm and have a needle put in your vein at your elbow area to have the blood drawn for Coumadin tests regularly. These home tests prick your finger like patients who check blood sugar. So if you prefer that to that, will be another reason why you might be a candidate for this. And the last question is, you're active in travel and you have other reasons that make it difficult to get tested. So all these things we talked about would be sort of a way that you might sort of just assess yourself. Is this something you want to take up with your doctor to consider?
Well, I think the second to last point you brought up there about a blood test from the vein versus a finger prick is a real important issue for a lot of people. The years and years of recurrent blood tests, it starts to run out of places to draw blood from. It becomes a challenge sometimes. I have a lot of people who complain, now they're looking for veins in the hand and different spots here, and it becomes a real challenge.
Yes. So we all have stories of the patients who have to go in and have hot soaks put on their veins to try to make them more prominent to be stuck, or they have a favorite phlebotomist who are always able to get that funny little vein behind the thumb or something like that. So yes, that's a real problem. Right. So I think that of the few patients that we have, most of my patients that I have on this home INR testing are patients who have mechanical valves, because before 2009, when this was approved for all the other indications, only mechanical valves were allowed. So I have patients who are on this for many years with the mechanical valves, and they definitely like it, and they find it to be very helpful, and they like the convenience of it, and they're in sort of a steady strategy. But most mechanical valve patients are younger, because the mechanical valve patients are always younger than patients who get the PIG valves, for instance. So that is part of it. And some people have said that as much as it's hard to draw blood from some of our older patients, some older patients lose the tissue in their fingertips, and it's hard to get the blood out from fingertips. So these are things that have to be discussed for patients. We've talked about, I think, a lot of things. I think we've covered many of these questions. The self-testing does seem to be covered by insurance, but we have to individualize, test it, evaluate that. If your doctor doesn't prescribe it, then I would say you're out of luck, because this really has to go through your doctor. I think that the options for this are for patients who are on Coumadin, especially the patients with atrial fibrillation. I want to just reemphasize that you really have 3 options now. Continue to do what you're doing, get your Coumadin checked in the office. Consider this home testing if it's suitable for you and your insurance. Or the third option is this drug we mentioned, which is new, called Pradaxa. And there's a couple of other new medicines which we expect in the next 2 or 3 years, so there'll be many options in that area. And then the last thing I would say is that the issue about getting trained is part of the setup of this. So let's go on to the next. So what's involved? So you asked this question, but let's do that.
The nitty-gritty of all this.
The nitty-gritty of this. So basically what happens is that if you decide, let's just use an example. If a patient comes to see me and we have this conversation and they want to be tested at home, we have them meet with our nurses who do this Coumadin issues regularly. Some paperwork is filled out with their insurance and some other information about them, and we send it off to one of these 3 manufacturers. And the manufacturers then contact the patient with this basically list of questions that I just went through. Is this something that you want to do? What's your insurance company? And then provides the patient with the specific information about what the exact cost would be. Because it's covered by insurance, it isn't a lot of cost, but there is some cost associated. And some patients have very little cost, say $10 or less per month, and some people may have more cost. And then if that's suitable based on what the cost that's required, we then can move forward with sending the equipment out. And one of 2 things happen. Either the patients are taught at home by the equipment manufacturer, someone is sent out to the house to teach the patient how it's done, how to prick their finger, or the testing can be done in the office. Let me briefly just show a picture of what this device looks like so that we can have that. Let me just go on to that. So there's a handheld device that we're going to have a picture of coming up. And basically you can see it's a pretty small thing. It looks just like a blood sugar check. So a little blood drop is put on in the bottom, it's pushed in, and you can see the number on the screen. This is just 2 different manufacturers. The patient on the left has a 2.8 number, and the patient on the right is a 2.6 number. So that would be the number that we would then get called to us, and the 2.8 or 2.6 are both in that range of 2 to 3, which we think would be excellent. And then there's some training results. I'll just show the next slide. This is just an example of patients who want more information. There is actually videos on the web. This is a company called Alera that has one of these devices. And this is a video that takes you step by step through what you get, what's involved, how you do the testing, and how it's communicated. So that's a pretty quick summary of what's involved. In terms of the conversation, I would say that patients who have some interest for the reasons that we talked about should have a conversation with their physician about whether this is something that they want to do.
And real quickly, one does not have to have internet access to do this either.
No, absolutely not.
Right, so.
Absolutely not. Just a phone. They would need a phone, but that's it.
Good. Okay.
So I'll just put up quickly a couple of websites that are available for patients who want to get some more information, just see what this looks like and what's not. One of them is called ptinr.com, and one is called inrselftest.com. These are the manufacturers of these devices. They have these websites. You don't have to be committed to using these devices, just for patients who want to get a little bit more information. So we'll just finish with some broad range summaries of things that we talked about. Do you have any other things that you think that we should touch on before we touch this?
No, I just think we're starting to run short on time, so let's
let's just run through the summary. I'll just put this up, this last slide, if we could. We have a slide of the summary of what the issues are. So this INR home self-testing helps maintain patients in the therapeutic range, helps them keep them in that 2 to 3 range because they can check more conveniently and more frequently if needed. It provides us timely alerts because if the patients are out of range right away, the doctor is notified. It helps reduce drug-related complications. When patients go on antibiotics, as I mentioned, they can get out of whack, so we can recommend testing more frequently once someone goes on an antibiotic or other drugs. It may reduce the time and burden of dealing with warfarin, as I described, don't have to come into the office. It may improve patient outcomes. It supports testing compliance so that physicians can get these things tracked down by the third party. And I'll just skip to the end that it does seem to have an impact on cost for the whole of public health services.
Great. Well, I do think we are starting to run short on time. So thank you for this summary and review of something I think is very new and exciting for our patients to make their lives much simpler. And so with that, we'll close the segment. So thank you to the viewers for joining us. This was another segment of Matters of the Heart. It was brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. I was joined today by Dr. Seth Bilazarian, and I'm Dr. Srivastava. Thank you.